welcome everyone to our latest CADASIL Consortium webinar. I apologize for my lack of video, but I will try to get by the best we can here with limited tech. And this video is being recorded. This presentation is being recorded, so you will have an opportunity to view this afterwards, as well as for those who registered but were unable to log in online. So I will notify folks via email when that recording is available. And otherwise, I have a very large welcome to Dr. Huey. We are very grateful to have you this evening. Your experience directing research and clinical trials in neurodegenerative disorders is valuable, and we are all very eager for this presentation. Dr. Huey is the director of the Memory and Aging Program at Butler Hospital, and he's also a lead investigator of our CADASIL Consortium research study at Brown University. In addition to countless professional accomplishments, Dr. Huey is well noted for compassionate and engaged relationships with study participants and colleagues alike. Personally, I've heard many great things from the families that he works with. He balances great achievement and a down-to-earth approachability. We're really grateful for his contributions to this project, and we welcome Dr. Huey. Thank you so much. And for individuals who would like to ask questions of Dr. Huey, please add those to the panel. The little Slido, it's called. There's an apps panel. It should be at the lower right hand of your screen. Questions will be visible to myself only, and I will be able to moderate those and address them at the end of the presentation. So again, welcome, Dr. Huey. Thank you so much. And if you're able to share your screen, we are ready to start when you are.
Okay, let's see. Thank you very much. Let me do this. Okay, can you see that all right?
We can, thank you.
Okay. Well, thanks so much for having me. I really appreciate it. I really look forward to presenting and talking with everyone here. We were just talking. So, this is just the disclosure. I'm a geriatric and neuropsychiatrist, and my main interest is in neuropsychiatric symptoms in neurological disorders. And I've worked mostly in neurodegenerative disorders, and so I've been particularly interested in neurodegenerative disorders that have present with prominent neuropsychiatric symptoms, including frontotemporal dementia, Huntington's disease, also Alzheimer's disease, Lewy body disease. But I'm pretty new to CADASIL, so I took the position after Dr. Steve Salloway stepped down. He's still very active, but I kind of have taken over day-to-day operations of the program here at Butler Hospital and at Brown. And since I've been at this position for 2.5 years, been working on this CADASIL project and really enjoying it. Really really valued getting to know patients, their families, the issues that come up. It's been incredibly rewarding, and it's been very interesting for me to see the similarities and differences between neuropsychiatric symptoms and neurodegenerative disorders versus CADASIL. So I'm going to talk a little bit about the neuropsychiatric and behavioral symptoms of CADASIL. There's actually very little data out there on this.
And before you get started, I'm interrupting. We had a request.
Sure.
if you could create a presentation mode, it might be a little bit more visible.
Oh, is it not doing that? Let's see. I thought it was, but I might be.
It's in the orange bar at the top. There's the save one, and then to the right of that, there's the undo, and then that presentation mode.
So, okay, so if I do, it's not the slideshow.
The slideshow would probably work if you, I see a little like square with a play button in it. And if you push that button, it should give you the options on the mode that you wish.
I'm using my laptop here, and I think it is,
okay.
That's the problem I have.
Well, we don't want to disrupt your flow. If this is what we have.
Let's try something for a minute here. Okay. Okay, oh, here we go. Is that better?
Let's see, it hasn't changed on my end.
Okay. So you're not seeing
The larger screen. No, at the top of the bar, I see like a save button and then an undo, and then there's the presentation mode
let me just try to
selection.
restart here.
Okay.
Okay, that's there. And then let's do, oh, I bet this is it, entire screen. Share, and then let me start this. Sorry for the delay.
That's okay. We appreciate the presentation and visibility if possible.
Okay, are you seeing what now?
I see the same size. Amy, do you have the larger screen? In fact, see at the top right, it looks like you can enlarge it. Maximize the shared content in the corner at the top right.
I'm not seeing that. Maximize.
Okay.
Oh, sorry.
That's okay.
Okay, well, let me just do this then. So it's small is the problem.
It's not a problem. I think, yep,
Okay.
there we go. You should be great.
All right,
Thank
we'll
you.
just do this. Okay, so yeah, talked about how it's interested, it's been really nice working. So we're going to talk about Catacil a little bit, specifically, although like I said, there's really not that much data. And then we're going to talk about related disorders and kind of lessons we can learn from that. And then talk about treatment. Again, there's very little specifically on Catacil, but I think kind of just more generally, treatment of neuropsychiatric and behavioral symptoms. And I want to leave plenty of time for questions and comments. I think especially these symptoms, it's very nice to, for people to kind of maybe talk about issues they might be having or, have a discussion, I think, as opposed to me just kind of talking to you. So a little bit of background of these symptoms. We talk about neuropsychiatric and behavioral symptoms. And the reason we talk about both of them is they express, things that are a little different. So the neuropsychiatric symptoms refer somewhat to more internal symptoms. So they might be things like mood symptoms, things that the patient is experiencing and feeling. And then behavioral symptoms refer a little bit more to kind of what they're doing. So someone could have external behaviors like being aggressive or things like that are not really an internal problem. Or they could have things like depressed mood, which may not manifest in a different behavior, but which are a symptom we want to address and treat. So I'd say, for the full term is neuropsychiatric and behavioral symptoms. We'll often just abbreviate it and call it neuropsychiatric symptoms. So neuropsychiatric symptoms are very common. I'll show you some data in Catacil. In neurologic and disorders in general, neurodegenerative disorders, they're very common. The way I think of symptoms of most neurologic disorders is as a three-legged stool here on the side, where you can have motor symptoms, you can have cognitive symptoms, and you can have neuropsychiatric symptoms, where neuropsychiatric symptoms are kind of viewed broadly as anything that's not motor or cognitive symptoms. So it can be sleep disturbances, it can be disturbances of motivation, it can be disturbances of mood. And when you think of it that broadly and kind of assess it that broadly, they are very, very common. The vast majority of patients with neurodegenerative disorders or Catacil will have some psychiatric symptoms. These symptoms are very costly and burdensome. So if you survey caregivers, they can be more burdensome even than the cognitive symptoms. For these disorders, especially things like agitation, psychosis, and they're costly. They are actually one of the biggest predictors of out-of-home placement are certain neuropsychiatric symptoms. So if people have certain neuropsychiatric symptoms, it greatly increases the chance that they can't be cared for at home and have to be cared for out of the home. They're poorly understood, I would argue, and this has been something I've been focused on in my research, which is trying to understand them better. I do a lot of consensus conferences, and we'll say the neurologist will say, well, the patient has Parkinsonism, and immediately everyone in the room thinks it has a certain anatomical associations with the substantia nigra, other parts of the brain. The neuropsychologist will say, and they've got memory problems, and we think of the hippocampus, other structures, and then we'll say, well, and they are suffering from depression. Well, there's no kind of anatomy that pops into people's minds, and I think that one of the foci in my research has been to try to bring neuropsychiatric symptoms closer to where we are with understanding motor and cognitive symptoms. The treatments we have, at least the pharmacologic treatments for neuropsychiatric symptoms, often lack efficacy to treat those symptoms and can have adverse effects. One of the most prominent ones is that the only medicine approved and shown to be effective for agitation, antipsychotic medications, can have the side effect of increased mortality, and actually has a FDA warning and black box for that. So we really, I think there's really a need to understand and develop better treatments for these disorders. Again, there's very little data. This is a really busy slide, but I'll try to kind of take your eye through it. There's very little data on CADASIL. Two studies have published the data from the neuropsychiatric inventory, which is one of the most commonly used measures of neuropsychiatric symptoms in neurodegenerative disorders, and it assesses the 12 symptoms you can see below. Delusions, which are false beliefs that resist correction. Hallucinations, which are seeing, hearing, or in other sensory modality, detecting something that's not actually there. Agitation, which can be either agitation, internal agitation of the patient being kind of upset, and also external, being aggressive to other people. Depression, which is we'll talk about a little more, but is depressed mood. Anxiety, elation, so elevated mood. Apathy, which is impairment in motivation. Disinhibition, which is a kind of a poorly defined symptom, but can mean doing some things they would have found embarrassing before that violate social rules. Irritability, aberrant motor behavior, which is repetitive behaviors or pacing or things like that. Sleep and nighttime behavior disorder, so sleep disruption, and then changes in appetite. And you can see that I labeled them CADASIL 1, CADASIL 2, or two studies that have been done on CADASIL and showing these different symptoms. I also have put data from our laboratory from several hundred patients we've evaluated with this scale, with Alzheimer's disease, with frontotemporal dementia, old elders without any diagnosis, Lewy body disease, and Huntington's disease. And you can see the CADASIL. So in the second CADASIL paper, they didn't actually report all of the symptoms of the neuropsychiatric inventory. But if you look, you can get some kind of ideas and trends. Delusions and hallucinations, so we call them psychotic symptoms, are actually quite rare in the two studies reported on CADASIL. Depression, more common in the first one than in the second one, but really quite significant. In one of the two CADASIL studies, the most common neuropsychiatric symptom. Anxiety, also in one of the studies, reported quite commonly. Apathy, reported again commonly, and disinhibition much less so, and irritability in both studies, one of the most common, and in the second study, by far the most common early symptom. Sleep and nighttime behavior, again, reported in one of the studies, and appetite much less common. If you look compared to the other disorders, clearly all of the disorders, neuropsychiatric symptoms are more common than reported in people who are clinically normal. But there are differences between the disorders, and some of it is the pattern. So, which symptoms are more common, less common, and some of it is the degree and intensity. So, if you look like behavioral variant frontotemporal dementia, Lewy body disease, have quite significant burden, neuropsychiatric burden, even more so than the CADASIL studies. This is the same data. This is looking only at the first study of CADASIL. But it's flipped the other way around. So this one's looking at the symptoms and then comparing between the different, just because CADASIL compared to normal controls and to different neurodegenerative disorders. And again, it says the same thing we were saying last time. Psychotic symptoms quite rare in CADASIL. Apathy, depression, anxiety, irritability, much more common. Not surprisingly, the more advanced the illness is, the more common these symptoms are. So this is from one of those two studies. And what it shows is the panel A is a functional measure, panel B is a MRI measure of vascular burden. And you can see with both of them that these common neuropsychiatric symptoms in CADASIL are much more common if people either are more advanced on a functional measure or on an imaging measure. So the more severe the illness, the more likely they are to have neuropsychiatric symptoms. And that's similar to neurodegenerative disorders. You see that same trend in Alzheimer's disease, other disorders as well. This is again from that same study, and it is showing when symptoms started. And the earliest symptom often was in that study was irritability, starting even when people were quite young, with the other ones following aggression, probably starting the latest, but most of the others starting mostly middle age in CADASIL. As I said, there's very little data in CADASIL. And the study that the CADASIL Consortium study is really hopefully going to address some of that. One of the many reasons it's an incredibly valuable study is that there really is so little data. There are special challenges, I would say, in detecting and studying neuropsychiatric symptoms in CADASIL. One is, and I think you saw this in the data I showed you, which had healthy control data as well, psychiatric symptoms are not associated with neurodegenerative illness are common. About a quarter of people will at some point meet criteria for some type of psychiatric illness in their life. And so we have a kind of a background of psychiatric symptoms that we have to take into account. As I've mentioned, I think we really, our understanding of the biology and neuroanatomy of neuropsychiatric symptoms is deficient, especially in relation to other kinds of symptoms. Our measures are mostly developed for Alzheimer's disease. And the neuropsychiatric inventory that I presented those data on is from Alzheimer's disease. And so they're not specifically oriented to CADASIL or other non-Alzheimer disorders. One thing I'm going to talk a little more about in a minute, and that's been of great interest to me, is that a lot of both our treatments and our kind of conceptualization of these symptoms is borrowed from psychiatry, from what I call primary psychiatric disorders, or psychiatric disorders in people without any neurologic illness. And I think that it's questionable how accurate those are for neurologic disorders. So, the idea being that depression in the context of CADASIL or in a neurodegenerative disorder really is not the same necessarily, both in the symptom presentation, the etiology, et cetera, as depression in, say, a young person going off to college with no neurologic illness who develops major depressive disorder. And one of the things I've been very interested in my research is trying to understand the clustering of symptoms and the definitions of symptoms better in neurodegenerative disorders and the ways in which they do and don't overlap with primary psychiatric disorders. Many of these we're relying on people telling us how they're feeling, and we lack some objective measures. Another thing that is an issue with CADASIL and with many other disorders is that people are under a lot of stress. So both having a neurodegenerative illness, a disability from that, from being just in a family with familial neurodegenerative or vascular illness are all risk factors for the development of psychiatric symptoms and can increase the rates of anxiety, depression, et cetera. So that's another factor we have to deal with. The title of this is Detecting Early Illness and Early Symptoms, and I think that is very important for the early detection of neuropsychiatric symptoms. Why do I think that's important? One is misdiagnosis or delayed diagnosis, and I think that probably a lot of people on the call have experienced this, where people can present with psychiatric and cognitive and other symptoms, and people will say, oh, it's something else, and it takes a long time to get to the correct diagnosis. For many of these disorders, it's certainly true for Huntington's disease, and it's true for frontotemporal dementia. The earliest symptoms are usually neuropsychiatric and behavioral. I think that a lot of these neuropsychiatric symptoms can kind of be the canaries in the coal mine, where subtle problems can result in these symptoms. And so, many of my patients are diagnosed with a primary psychiatric disorder, depression, anxiety, when really they have a vascular or neurodegenerative disorder. And this is a problem as we're working on treatments, because almost all the treatments that we are working on probably will work best early on in the illness. And so we really need to be identifying patients early to benefit from treatment. The other problem with not detecting and measuring well and understanding these symptoms is that we can't then use these symptoms as outcomes for a trial. So, for example, if patients have disorders that present with motor and cognitive and neuropsychiatric symptoms, we'd really like to be able to do a trial where we try to improve, that are open to improvement in any of those symptoms. And whereas a lot of trials, and I'm again a little more familiar with this in the frontotemporal dementia world, where there's an overlap between ALS, amyotrophic lateral sclerosis, and frontotemporal dementia, where the trials have been based and enrolled patients only on the motor symptoms and not on the neuropsychiatric and behavioral symptoms, but that you lose power and lose the ability to detect that your medication is actually helping them. Clearly, neuropsychiatric and behavioral symptoms are important parts of these illnesses, and so we need to understand them to understand these illnesses. And as I said before, these symptoms, psychiatric symptoms, are often most interfere with quality of life between motor and cognitive and psychiatric. And so we really need to identify patients who can improve from treatment. This is a slide just getting to that point I was saying about that psychiatric illness in young people really is probably not the same as what we're seeing in neurodegenerative or vascular illnesses like CADASIL. This is the slide where it shows the Venn diagram, and in the middle of it is the DSM, which is kind of the psychiatric Bible definition of the symptoms of major depressive disorder. And you can see them listed there: depressed mood, anhedonia, which is not taking pleasure in activities, sleep disturbance, psychomotor changes, concentration, energy, appetite, poor self-esteem, suicidality. And what you see with different disorders is that they overlap somewhat with this, but not entirely. So again, when I've worked a fair amount with frontotemporal dementia, they have apathy, they have anhedonia, they don't take pleasure in things that they used to take pleasure in, but they generally have no depressed mood, no poor self-esteem, no suicidality. Huntington's disease, they will often have depressed mood, anxiety, but often with a much more significant contribution of mood lability, and irritability, so more kind of mood reactivity and obsessions. And so one of the things that, if we just are giving, so if you give many of these patients a depression measure, for example, for patients with frontotemporal dementia, they often will score on it, but you're not really capturing depression, you're capturing pieces of the syndrome. So talking a little bit more explicitly about lessons from other neurodegenerative disorders, this is a project where it was my first R01 that I worked on, and it was a large family. We basically zoomed in on one large family with a tau, a MAPT or tau mutation. And those mutations with very high penetrance result in frontotemporal dementia. You can see it's quite a large family. The numbers there refer to offspring. So it was a family of over 100 members. And we were very interested in assessing these people, following them over time, and especially from a psychiatric and neuropsychiatric point of view, following them and seeing that how people did. And so one of the things we did is we did full psychiatric interviews, which is called a SCID, or structured clinical interview, on all of the people at every visit. And then we compared the people who were carriers, were mutation carriers, to people who were not carriers within the families, and compared them to the general population as well. So this is kind of the gold standard of psychiatric diagnosis. And if you look at the data here, you can see that in the dark green is compared to the general population, and again, this kind of background of psychiatric illness. And then the blue are people who were in these families but didn't carry a mutation that causes frontotemporal dementia. And then the light green are people who were carriers, who were all people who, most of whom, the vast majority of whom, were not diagnosed with frontotemporal dementia. They may have been having very, very early symptoms, but most were considered normal without symptoms at the time. And if you look, you can see that some interesting patterns emerge. So one of them is that for major depressive disorder, we found it was significantly more common, and the same thing goes for panic disorder, that in carriers than in the general, in non-carriers than the general population. So just being, we don't know why that is exactly, but just being in the families, you're at higher risk for having a psychiatric mood or anxiety disorder. And some of that may be from, this is very stressful. People may not know their genetic status. That can be very, very anxiety provoking as well, too. When you looked at the carriers, they actually, interestingly, had very little depression and less panic attacks and disorder than their non-carrier siblings, which seems kind of counterintuitive. But then you look at depressive disorder NOS, which is symptoms like anhedonia, other depressive symptoms that aren't dysphoria, aren't feeling sad, and they had more of that. So this supports that idea that these people are not really showing major depressive disorder like we see in the psychiatric manuals, but kind of presenting with their own syndrome. If you look at psychiatric disorders, and this is work that has been done within psychiatry, some people have done some very interesting work in taking psychiatric disorders and then looking at what is the factor structure? And what that means is, what are the underlying factors that underlie these different disorders? And this is from one of those papers. And you can see at the bottom are all of these different psychiatric disorders. And this is not to say these are the same, that they are actually very different from each other. But when they do factor analyses on very large numbers of people with psychiatric illness, they get, these 5 factors quite frequently. The strongest factor they find is internalizing. And that assorts with both mood disorders and anxiety disorders, where it appears to be just kind of feeling bad, feeling distress, feeling emotional distress. The other factors they have here are thought disorder, which we often see in psychosis, externalizing, which is kind of acting out against others, and antagonism, similar, and then somatoform, which is having more physical symptoms. But really internalizing is usually one of the strongest factors in primary psychiatric disorder. And we think that that is actually what is getting, for our frontotemporal dementia patients, often decreasing, is these internalizing kinds of symptoms, and resulting in a kind of an emotional blunting. And we do see that with the data as well. So we looked at cortical thickness, which is a measure of the cortex health in patients with frontotemporal dementia. And we found that the thicker the cortex, which is the healthier their cortex, actually the more depression they had, the more sadness. And so in the right, it wasn't quite significant in the left, but in this part of the brain called the ventromedial prefrontal cortex. And so, we think from these data that damage to this area, or neurodegeneration or vascular damage, can result in a syndrome of kind of apathy, emotional blunting, which we do see in our measures as well. But it's an example of how you wouldn't detect this if you were using taking a more typical measures or taking a more typical view. You actually have to take the kind of very counterintuitive view that damage will act to this area actually prevents the patients from showing what we would think of as appropriate dysphoria anxiety. So we did a study, which we're just writing up now, called NAPS, which stands for Neuroanatomical Associations with the Factor Structure Underlying Neuropsychiatric Symptoms in Alzheimer's Disease and Related Dementias. It's a long title. And basically, it's not actually that fancy of a study. Really what we did is just very extensive psychiatric measures cross-sectionally across several hundred patients with different neurodegenerative disorders and matched elderly controls without neurodegenerative disorders to see what are they presenting with and how is it the same or different from psychiatric disorders. And these are just the participants that we have data on at the moment, which is over 200 people, mostly with Alzheimer's disease, but with other neurodegenerative disorders as well. Let's skip this. This is just who they are. And one of the main measures we did with them is, I mentioned that structured clinical psychiatric interview. We did the whole thing. So usually when you give this interview, you skip, if people say no to one question, it allows you to kind of skip. And what we did is we gave every single question in there, which is over 1,000 items. And the goal of it was we were using this measure to just take a very, very broad, hopefully unbiased survey of what psychiatric symptoms these patients were showing. And then we took the items which were assessing kind of primary data as opposed to secondary data, and to look at in analyses. And we did similar to what those other researchers did with primary psychiatric disorders. We looked across them to see kind of what the factors were that came out. And we came out really pretty reliably with 8 factors. Starting on my right, the one was this emotional blunting and apathy. So again, these were people who were apathetic and were not depressed, though. But if anything, they would not report, they were reporting less depression and anxiety than other patients. We found chronic anxiety to be another factor, so kind of anxious all the time. We found sleep disturbance or insomnia to be its own factor. We found hypersomnolence, interestingly, to be its own factor, which is basically, as opposed to sleeping too little, sleeping too much. Patients who are sleeping fine at night and then they sleep during a lot of the day as well, and then sleep fine the next night too. We found acute anxiety to separate out from chronic anxiety, so that would be episodes of panic. We found aggression, agitation to be its own factor, and then obsessive compulsive or repetitive thoughts and behaviors. And then the last factor we found was this dysphoria, so feeling sad, feeling bad, which was separate in our factor structure from lack of motivation. That it started on its own. And the idea is that these factors will associate with anatomical structures across these disorders. When you look at the correlations of these different factors, there's a lot here. I'm not going to go over it, but you see some really interesting things. You see, the green means a negative association. So you see basically a negative association between emotional blunting and episodes of panic. Again, this idea that the patients who are having the apathy, emotional blunting, are having trouble, don't get as anxious as other patients. You see, associations between, so for example, generalized anxiety and sleep disturbances are quite common. So, appears that kind of anxiety interfering, causing insomnia. Anyway, there's a lot, and we also see close associations between depression and anxiety, so that people who are having anxiety are often feeling down and sad as well. When we look across these different neurodegenerative disorders, we see similarities between Alzheimer's and Lewy body disease, where they have a lot of anxiety, sleep disturbance, hypersomnolence, and depression. And then with frontotemporal dementia and Huntington's disease, which are more frontal subcortical, involving a kind of a different anatomy than Alzheimer's disease and Lewy body disease, we see a kind of a different pattern. We see a lot of emotional blunting, apathy, and a lot of repetitive behaviors and agitation. So it does appear in a gross way to be sorting with the neuroanatomy. And we have imaging on all these patients, which we're now looking at to try to pin this down a little better. As part of this work, we have developed a new measure, which is designed to not be as Alzheimer focused and should be applicable to CADASIL, to basically across neurologic disorders. This is just one little sample of it, but based on these analyses and more based on the kind of observed factor structure we see in these patients. So we should be rolling out pretty soon. We're just getting pilot data on it currently. And then we're also following up. We have another R01, which we're finishing up, where we're looking at physiologic associations with these factors and with neuropsychiatric disorders in general. The idea being that these systems that are being affected in these disorders exist to modulate how the body reacts to stressors and to emotion and other processes, and that we should be able to detect that. So using the RDoX paradigm, which is something that the National Institute of Mental Health has put forward as kind of experiments that can probe different body systems. We have been doing this in the same patients that were getting the data I showed you already. Those same subset of those same patients are doing what we call negative valence and positive valence tasks designed to elicit physiologic responses, and we're seeing the ways in which those differ from controls. Then part of the goal of this is, I showed you we're making a measure. This is to kind of, one of the goals is to determine more objective measures of neuropsychiatric disturbances in these patients. So let me talk a little bit about treatment of neuropsychiatric symptoms in CADASIL. Now, there's very little data, so this is really based more on kind of my experience and across neurodegenerative disorders, and now treating and seeing patients with CADASIL as well. So let's talk about general principles. So one thing is, and it often comes up when I'm seeing and treating patients with CADASIL or other disorders, is people will say, well, of course I'm sad. I have this disorder, I have disability. And one of the things, I've talked a lot to patients and families about is that when we're treating psychiatric symptoms and these disorders, the point is not to say that you shouldn't be sad, you shouldn't be grieving, you shouldn't be mourning, all of these very important processes. The point, the sort of larger overall goal is to try to intervene if those symptoms are getting in the way. So in other words, by definition, depression is where the depressed mood has gotten to the point where you're not able to do the things you need to do. And so our goal is not that people don't feel sad, not that people aren't having a hard time, but more that it doesn't get, that people don't get so much in a hole that they can't kind of do the things that they want to be doing, enjoying being with their family, enjoying the things they can enjoy. In general, pharmacologic and non-pharmacologic treatments work best together. So, I do have patients who will want one or the other, but really, if you want to get best, people want to get better quickly. Often, a combined approach is used. This is a kind of psychiatry terminology, but egosyntonic and egodystonic. What those refers to, egodystonic means symptoms that are unpleasant to the patient. So those would be depression, anxiety, and egosyntonic are symptoms that are not unpleasant, and that can be kind of more the behavioral symptoms, agitation, things like that. And so sometimes when we're treating patients, most of the time when we're treating patients, we're treating the patient, we're trying to help them feel better, but sometimes we're helping them be in the system. So if someone's having aggression, agitation, that affects the whole family, that affects the caregivers. And we may treat something, even though it may not be bothering the patient so much, and apathy kind of falls into this category as well, but because it's affecting the family unit. Also, insight can really vary between patients. And another thing that we deal with in this area is obviously caregivers. And the fact that it's, we're not dealing with just the patient, we're dealing with the entire system. I'll run through some symptoms quickly, and again, I want to leave time to hear from people about what issues they're having. Irritability, and you saw that in the data I presented, a very common neuropsychiatric symptom. We will often use SSRIs, which are for pharmacological treatment, which are selective serotonin reuptake inhibitors. They're a class of antidepressants. There's actually most of the kind of antidepressants you would have heard of, sertraline, fluoxetine. They can have efficacy against irritability. Also, psychotherapeutic non-pharmacologic interventions can be very helpful. And we tend to, so psychotherapy, a lot of times when I bring it up to patients, they think, oh, it's lying on the couch and talking about your mother. And a lot of the psychotherapeutic interventions we use these days are more what we call directive. So they're not about uncovering past traumas, or they're more about dealing with the symptoms as they come up. So for example, cognitive behavioral therapy or behavior therapy is one of those types of therapy. And in relation to, say, irritability, it can focus much more on what are strategies you can do if you feel like you're losing your temper to help yourself calm down? Deep breaths, getting a break, that kind of thing. And it can be very helpful for irritability. And then obviously something like irritability is a good example where it's you're part of a system. And so sometimes some of the intervention we do is to spread out the caregiving, make it so that often for caregivers, they're really 24 hours with the patient, and to try to intervene on that. Apathy and emotional blunting I brought up already as an important symptom. For this one, I really think the non-pharmacologic interventions are where the money is. And so one thing is to have structured, scheduled activities as opposed to leaving things open-ended, because people who don't have motivation, obviously then are often will then not do things, not if it's kind of open-ended. Whereas if they can get in the habit of something, it can be better. Often we talk about having other family members or caregivers having to take over responsibility for planning events. So something we hear commonly is, oh, my husband is having these motivational changes. He was the one who did all the social planning, and now it's very disruptive that he's not, and someone else may need to take some of that over. At the same time, we do want people to do things, and that's the difference between apathy and depression, is that with apathy, they actually can have an okay time if they go do something. But at the same time, with people are having significant apathy, they won't be as active as before. And so we do, discuss having some tolerance for that. There are some changes in motivation and may not be as active as before. Well, skip the sleeping part. For pharmacotherapy, the evidence is very mixed, and the stimulants have been the medication that's been most studied. There is some in neurodegenerative illnesses, some positive evidence for them, but they can have pretty significant medical side effects. So again, I think of non-pharmacologic interventions as being the first place to go to in apathy. Depression. So one thing about depression, very important to distinguish from apathy. So depression being sad, crying, apathy being motivation. They can overlap, they can be separate, but it's important to evaluate for both of them. Antidepressants are the pharmacotherapy of choice. Again, often SSRIs is the first choice. There's a range of psychotherapeutic interventions available, and they have very similar efficacy to the medications. One thing just to keep in mind is there's actually very little literature on this, but efficacy of psychotherapy in depression and for all of these can be affected by a patient's cognition. So if someone really has a lot of trouble with memory, it can be very hard for them to integrate in the message, the learnings from psychotherapy, and psychotherapy may be less useful in those patients. Anxiety, I've shown you there's kind of acute versus chronic. The pharmacotherapy, we often use antidepressants. Even though they're called antidepressants, they can have efficacy with anxiety as well. And psychotherapeutic interventions also can be efficacious. Sleep symptoms, really it can be either sleeping too little, sleeping too much, or both. Often it's where people are sleeping too much during the day and then awake at night. The first intervention is always sleep hygiene, which is basically the behaviors we have around sleep. I won't go into them too much, but that could be a longer conversation about what is the sleeping pattern, what are people doing to interfere with sleep or to help sleep. Adjunctive pharmacotherapy can be helpful. We generally will start with kind of milder agents and work up as to more stronger agents as needed. And a lot of the things we start with, often don't work, but are really quite well tolerated. So if they do work, we're happy with that. But they can be helpful in addition. Agitation, aggression, in my experience, can be associated or independent of emotional distress. So I think of kind of hot versus cold agitation, so aggression. So a lot of my patients with, where it's either they're very upset about something or they can just be aggressive without being upset. For this, it's very important to get good data and good information. And so journals and logs are helpful. What precedes agitation? When does it happen during the day? What medications help? When do they help? There can be pharmacologic interventions. Antipsychotics have more evidence for being helpful, but they do have more side effects. And one question that comes up is kind of, does a patient take a medication just when they're getting agitated versus every day? Again, the conversation with your doctor. We tend to not use as needed so much, just because by the time someone gets agitated, they often won't take medications, and it can take too much time for them to work. And then talking about non-pharmacologic interventions, which are very important for including environmental and caregiving interventions. So identifying triggers, avoiding them or ameliorating them in some ways, and increasing caregiver help are two non-pharmacologic interventions we often use. So I will stop there. because again, I want to have some time for questions, etc. Yeah, stop there.
Thank you so much. I learned so much. That was an excellent presentation. And also thank you for your work in developing more CADASIL specific measures. I think that's really where we're headed and critically needed. We do have several questions, so I'm going to get right to them. I noticed some of them have been answered during the presentation, but I'm going to read them again in case you'd like to add anything further. But if your question is, I'm going to read them in the order they came in. So if for any reason we don't have time to address it, please forward the question again to our email info@cadasil-consortium.org, and I'll make sure that we can follow up afterwards. But let me jump right in to our first question. Have you found that there are medications for individuals with CADASIL that are more helpful than others for the psychiatric symptoms of CADASIL that seem to trouble them the most? For example, apathy, mood regulation, and anger management. And in fact, a second question also came in under apathy, so maybe we could add that. And that question said, apathy is my most serious symptom. I'm 66 years old. So far, my psychiatrist has not found a treatment to help with this. So I know you suggested a lot of non-pharmaceutical interventions, but perhaps there's a moment you could take.
Yeah, so apathy, people kind of call it the common cold of neuropsychiatry because it's so common and very hard to treat. Um, haven't found, so the interventions with CADASIL, so I haven't used much pharmacotherapy for apathy um, in CADASIL. Part of the reason being I worry more about some of the adverse effects in CADASIL. So really the medications that we have any evidence for, and it's mixed. So it is not clear efficacy. Are the stimulants, and the problem is that they can have raise blood pressure. They can do other things which I really worry about in CADASIL, and so and the efficacy is not certainly not great in neurodegenerative disorders. Now, people have not, to my knowledge, not tested specifically for CADASIL stimulants, but again, we're kind of basing it on our experience with other disorders. So that's part of why I really kind of put forward the non-pharmacologic interventions, because it's really the pharmacotherapy of apathy is not great. We don't have great tools. And so, I tend to spend my time with patients focusing on working on the non-pharmacologic, and I find I get more out of it too, and the patients get more out of it. So focusing on again, readjusting our expectations. So, if some of my patients, if they can do, one or two things in a day, that's a win, and that are kind of really active. Trying to get it on a schedule. So again, focusing, if it's say on exercise, that's happening at the same time every day, so that people get in the habit of it. Using technological aids, so alarms that go off, things like that. And again, and having other people, caregivers and others, to kind of set up activities, take a little more of an active role. Now, working with a therapist can be nice in the sense, I mean, they can have expertise in this, but also it can provide more frequent check-ins that often then people can have with their neurologist or something like that, where we can kind of see what's working, tweak it. But it's a very tough disorder to treat pharmacologically and very common. So, it is, across all of these neurologic disorders, one of the most, if not the most common symptom.
Thank you very much. I am scrolling down. Here we go. Have you found value in palliative care coordination in your practice for individuals with CADASIL and their families and caregivers?
Yes, and I'm a little biased. My wife is a palliative care doctor for neurologic disorders, so I kind of, I've absorbed some of that from her. Um, yes, and I think palliative care has kind of rebranded itself, where it's about more, about symptom management throughout the course of an illness, not just end of life. And I kind of view that as what I do in psychiatry as well with patients, which is that kind of returning to that point that if I have patients with, say, I just see patients, let's pick a different sort of maybe like ALS, which can progress quickly, and I see my goal as a psychiatrist seeing that person to basically help manage symptoms that are getting problematic or getting out of control. And again, not trying to say that they shouldn't be having a hard time with this or that they shouldn't be mourning and grieving and dealing with disability. But in my experience, when people get very, very depressed or very, very anxious, they can't deal with these things. And the time to deal with these things and to be with your family and things becomes all the more precious. And so I see a real overlap between psychiatry, neuropsychiatry, and palliative care. Whereas palliative care brings in a little more of the physical side of dealing with physical symptoms as well too. But yes, I think involving palliative care is very important, and I think we kind of have a similar outlook on trying to help people.
Thank you, Dr. Huey. I've got two more questions if we can manage. Have you seen CADASIL patients that oscillate between hot and cold with regard to emotional distress, or are they generally one or the other?
So you're talking about like the agitation, aggression?
I think when they say, yeah.
Yeah. Usually with the agitation, I kind of find it being people tend to often go one way or the other. And again, I've had a lot of experience with frontotemporal dementia. I think I showed you, they kind of will get this emotional blunting where it can be aggressive, but it's not in response to something. I do, there can be though, and Dr. Paulson knows this very much. There is this symptom of kind of emotional lability where people are very reactive, may get aggressive. And a classic disorder that's very associated with that is Huntington's disease, where people can really often one of the first symptoms you see is kind of flying off the handle, road rage, this kind of real emotional responsivity, or excessive responsivity. So definitely, all of these systems can kind of dysfunction, and so you can either kind of become there are patients who kind of have trouble mounting an appropriate emotional response and can become emotionally blunted or apathetic, and then patients who also can have excessive emotional reactivity. And so, again, that's one of my points about the measures, is that some of these things you don't really see in primary psychiatry. Primary psychiatry deals really with internalizing symptoms, anxiety, depression, that kind of thing. It deals much less with these other symptoms. So I think we kind of need to develop our own. But I think with the switching between hot and cold, maybe describing kind of a lability, or even then there's things we can get into it like pseudobulbar affect, which are basically where people can have emotional reactivity that is excessive as well.
Thank you very much. Our last question here. Why do some individuals diagnosed with CADASIL suffer adult onset tonic-clonic seizures?
A little out of my area, but when you get damage, any kind of damage, it can be any kind of damage to the brain can cause scarring that can result in what we call a nidus, which is a focus for a seizure, where electrical activity can become abnormal in that area. And then really all a seizure is that electrical activity spreads. So patients with CADASIL can get that from the vascular damage. My patients with advanced Alzheimer's disease can develop seizure disorders from, again, just the damage. People with traumatic brain injury, any kind of injury to the brain can result in seizure activity, unfortunately.
Thank you. We did have one additional question, also might be a little bit out of your league, but if you're willing to, on the surface, address it, or at least we can see if there's any research out there. But the question asks if there's any correlation between childhood sexual abuse and trauma and the person then being more likely to be affected by a mutation such as CADASIL or any kind of sexual trauma, childhood or otherwise. Is there any research or association?
Well, that's an interesting question. And, some of the data I was presenting to you from these large families we've worked with where we do kind of intensive psychiatric phenotype, assessments throughout their lives. That I think it brings up that issue of, if things like that happen, so trauma, um, that increases your risk of developing a psychiatric disorder, depression, anxiety, different kinds of disorders. And so, how do we start to tease that apart in people? So I would say, it's less likely to, to interact with, well, less likely to interact with the mutation, but it can increase the rate of primary psychiatric disorders, which then can interact with it. And those were some of the data I showed you, were that where people in some of these families with where half the people are getting sick, it is very hard on them and hard on the family. And so even people without the mutation and people probably with the mutation, that the psychiatric background can kind of change, and people can have harder experiences. Again, if half the people in the family may have, not be able to earn as much of a living and things like that, it can really, it makes a different kind of psychiatric background. So one thing I've kind of advocated in the field is we have to take that into account. And so a lot of the studies, I do and other people do, I use as controls, not just the general population, but families with genetic genetic illness, to kind of capture a little bit of that. But at the same time, all of these people, and even though I'm talking about neuropsychiatric symptoms, are at risk for primary psychiatric disorders and for events in their lives more at risk that can predispose for that. So it's complicated, but that's part of what I find kind of a puzzle I want to try to kind of untangle a little bit.
Thank you for addressing that. There's one last question that came in, might be an interesting one to end on. There's just some theories that the German philosopher Friedrich Nietzsche suffered from Catacol. Any thoughts, or have you heard that before?
You're showing my ignorance of philosophy. I know of him, but I don't know. That's interesting.
Yeah,
And yeah.
we'll all be Googling that later.
Yeah, you're showing that I should read more philosophy, because I don't know enough about his history to give an
Well,
answer.
I'm sure you do plenty of reading, and we thank you, as is made obvious by the excellent presentation that you offered to us. I will make this recording available as soon as possible, and anyone registered can then access that and reach out with any additional questions. We're really grateful to you. Thank you so much for your time and expertise.
Thank you. Pleasure talking with you all.
Hope everyone has a great night. We'll see you next month on November 17th. It's a little bit odd that it'll be more in the middle of the month, but we're hoping to accommodate holiday schedules. So look out for more news. For participants who are on the line, if you still want to send in a clip on what you're grateful for this year, what you're hopeful for this year, you can send that also to our info box. And we're compiling a nice gratitude reel that we're going to share in December. So I thank everybody for joining us tonight, and I look forward to staying connected. Have a wonderful evening.